Okay, so next up we have Dr. Sharon Cobb as well as Dr. Mohsen Bazargan to present on, actually it's an optional workshop that's on how to take our CPBR research to the next level, how to write hypotheses and specific aims. So Dr. Bazargan has already been introduced, and Dr. Cobb is the director of RN to the Bachelor of Science in Nursing program and an assistant professor in the Mervyn M. Dimally School of Nursing at Charles Ardrey University of Medicine and Science. She received her Ph.D. in nursing science from the University of California, Los Angeles, in which her research focused on chronic physical and mental health issues among older African Americans. In addition, she received her baccalaureate degree from University of California in Berkeley and master's degrees in both nursing and public health from Charles Ardrey University of Medicine and Science. Dr. Cobb is a current fellow in the Clinical Research Education and Career Development Program, funded by the National Institute of Minority Health and Disparities. She recently completed a fellowship with AltaMed Health Services that focused on treatment approaches for opioid users. Additionally, she is the program mentor for 2 pipeline programs at CDU that assist ethnically diverse students to pursue a doctoral degree in nursing at both UCLA and UC Irvine. Dr. Cobb has served as a co-principal investigator on several grants focused on cancer survivorship and caregiving among African American and Latinx groups, which was funded by the NIH U54 CDU UCLA Cancer Center Partnership to eliminate health disparities. Presently, she's leading a study that focuses on training clergy wives and widows to become cancer survivorship leaders in the community. For her work on COVID-19, she currently serves as a co-principal investigator on a collaborative grant with Tessie Cleveland Community Services Corporation to provide mental health workers on COVID-19 education and improve health outcomes for African American, and Latinx groups with mental illnesses. Additionally, she is a co-investigator on a recently funded grant that collaborates with African American faith leaders to develop COVID-19 reopening protocols for churches and improving chronic care management for African American parishioners during the COVID-19 pandemic. So thank you, everybody, and welcome Dr. Bazargan and Dr. Cobb.
Thank you so much.
One thing that I want to add, can you hear me?
Yes.
Okay. One thing that I want to add to your kind mini of Dr. Cobb is that very important point. Doesn't matter how many papers we publish or how many grants we get, if that quality is not there. This quality that Sharon has is very unique. He is kind, dedicated to underserved community, hardworking, as I said, kind, hardworking, and dedicated to this community and similar communities. So personally, I'm honored really to work with her, knowing in last 2 years, I worked very closely with her and I know her heart. I know how much she's dedicated to this community. Many nights I observed her to work till 2 a.m., 3 a.m. When we are on Zoom, I see that she's there and, you know, she is truly an asset to this university. I hope that, you know, we all appreciate that. And she is the role model for many of our young faculty and postdoc in this university. So Sharon, thank you for being here. Again, I'm very proud of you. So I don't think Dr. Kibe is here. She left, she was here earlier. But anyway, Dr. Kibe also is a very knowledgeable, dedicated individual who is a director of physician assistant program. And she's also one of our co-investigators for this project. What I would like to do today with Sharon is to show you how we develop a community-based participatory research that target African Americans parishioners, specifically older adults in South Central LA, that we can reduce risk of COVID-19 among them. At the same time, we can improve their healthcare utilization. As you noticed a few minutes ago, Sherwin talked about, Dr. Asari talked about healthcare utilization among African Americans. And he mentioned that, for example, African American men are less likely to use healthcare resources and compared to their white counterparts. So here we know that because of COVID-19, many older adults stopped getting medical care that they needed. They are diabetic, hypertensive, with heart problem, a different type of chronic condition. Some of them are cancer survivor, etc., with a stroke, etc. So because of COVID-19, many of them stop using regular health care that they were supposed to get it. So the objective of this project, me and Sharon initially get together and said, okay, what is that we want to do related to COVID-19? It was late, I believe, May, when NIMHD released a request for applications. So knowing that, saying all of this with African American community, so I'm a gerontologist, and also Sharon has a long history of working with older adults as well. So her dissertation, Ph.D. dissertation at UCLA, also tapped older African Americans. So we build up based on our background to see what we could do for African Americans community. So Sharon, you want to talk about this page?
I do, but first, can I thank you? You didn't give no time for me to thank you. Hi, everyone. Good afternoon. First off, let me say thank you for just expressing the bio. You know, it's just some of the work because Dr. Bazargan, I consider him my father here. He has just been this gentle giant for me, and I'm so grateful. I wouldn't be able to get to the number of places without him. And I think that's just what it means coming from myself as a junior investigator. And it's surrounding yourself with mentors and leaders who could guide you and know what's best for you. There's plenty of people on this call that I would not be remiss if I didn't have them in my life because they guide you and they keep you in check. When something happens, they got you to say, I don't think you're going the right way. And so I think it's important to always acknowledge those people. You know, there's plenty of people I saw in the chat, but without Dr. Bazargan, without people such as Dr. Booker Bonds, Ms. Plus, Dr. Shaheen, you know, guiding and being able to approach people, I think that's important. And I think that's what we're encroaching on the topic today, is looking at this community level partnership. Just as Dr. Bazargan introduced, without skip past the part about me, but what he pushed on was this community level. COVID-19 has really touched on our communities like we've never seen before, haven't seen. And because of that, we need to pinpoint the places that have been heavily impacted by the pandemic and not really focus on the African American churches. As he said, I'm from this area. I grew up here. I went to King Drew High School. I know this area. So I know how challenging it has been with the negative impacts of this community. And when we look at older African American adults, especially those with comorbidities, you know, even last night we were on a call and some of our faith leaders were saying that individuals aren't even seeing their healthcare provider because they're nervous to go to their doctor. And if you're not paired with your community leaders, how would you know that? If we're looking from an academic scientist, a research perspective, how would we know that? So this is where we know the literature, but at the same time, what we'll talk to today is being able to partner with being able to collaborate with your community partners. Because when you are doing intervention work, looking at studies, when you're going out into the community, it's important that the community is also benefiting from this. And we're going to touch more into it today on how we'll go into that. But I think that just expresses a little bit on how we started with the collaboration with African American church leaders in South Los Angeles. I don't know if you want me to go more into detail about the project or how would you want me to go, Dr. Bazargan?
Sure. I did want to first emphasize that we have a 50 years of close partnership and collaboration with faith-based organization in South Central LA. So working with community-based organization, especially faith-based organization, requires mutual respect. Mm-hmm. You cannot just go there and collect the data and come out and publish it. Mm-hmm. If you do so, then next time they are not going to let you in. So you have to build the trust. So we have 50 years of close collaboration with faith-based organization in South Central LA. And it's not only churches. I think, I don't know if Dr. Shaheen is here or not, but we also work, Dr. Shaheen work with, Muslim organization. Earlier, a few years ago, we published paper on breast cancer screening among Muslim community, Muslim women. So this is quite difficult if you don't know your community and if you don't respect them enough when it comes to research. Let me put it this way. 15 years ago, 20 years ago, or maybe 15 years ago, if you write a proposal and submit it to NIH and tell them that you want to first, conduct, let's say, a qualitative study to figure out what kind of intervention you want to propose, they will reject it immediately. And so, well, he doesn't know what he's doing. But right now, this scenario has been changed. Mm-hmm. If you want to conduct a study from very first day, you have to work with community advocates and individuals that they are gatekeeper and they, that they can connect you with the community, such as our community faculty who are here. So this project was designed to work with church leaders, and we told the funding agency, give us a chance to work with community, to work with the church leader, to get their input. They know each other in order to develop the strategy that we would like to see that reduces the COVID-19 risk. I appreciate if Sharon goes to detail of how we work with church leaders. Sharon, would you please?
Yeah, I can do that. I think touching on the cornerstone, we have to look at work. Most of the time we've all been accustomed to community-based participatory research. But with leaders such as Dr. Loretta Jones, having that type of grounding where she elevated to move into community partnered participatory research is fundamental. And that's because you need to make sure that when you're working with the community, that they are partners. Now, we're familiar with working with the African American and Latinx populations, but no matter which population you go into, now NIH is looking to see, do you have that community advocate? Do you have that stakeholder on board? And, because they know about the community and they like to see that shared community benefit. We talk about sustainability, how that's coming along, how that's becoming important for grants. And that's because they want to see, once this funding is gone, can what you said is the intervention still continue? And a lot of times that can continue if you're bringing community partners in to set up that process and that system. And that's exactly what we aim to do with these faith-based leaders. Now we pulled together, we have more than 10 now, but our aim was to take 10 leaders from these African American churches within South LA and to say, hey, how can we come together in a shared benefit to make sure that we're improving the health of your church members and the community? Not only are we getting to see the results and what will change, but you also will benefit by helping to know, is there increased management of care among your parishioners? And as we know, faith-based leaders are really experiencing it. For instance, one of them said this will be their 15th funeral in 3 weeks. And so that just goes to show how when you have this shared benefit, not only are we providing support services to both the parishioners, but we're also working with the pastors. So with these 3 substantial outcomes, what we aim to do was to see, how can we come together to ensure that the outcomes that we're putting out, which will eventually become our specific aims, what outcomes are we setting out to make sure that they are community driven? And that's an important part to look at. So with 1, we said as a result, like I said, CPBR with Dr. Loretta Jones, as a result of this community participatory intervention, 10 predominantly African American churches in South LA will adopt federal and state of California guidelines for COVID-19 preventative practice within their church. And so just from that line alone, we've already started to tell the reviewers how many people will be involved and exactly what are we aiming to do. By fully implementing these guidelines, we're already saying who will be exactly touched or be affected by this intervention. And in there, we're saying over 3,000 parishioners. Now, that doesn't mean that potentially you're going to have 3,000 in your study sample, but just by us touching with the leaders, that's what's going to bounce off by having the effect from that intervention. And so this is how we start to draw in when we've worked with our pastors and making sure, well, now with this aim, now we're going to start thinking that aim will be the guiding light. Because now that we have this aim, now we're going to start thinking, okay, well, how will these pastors be able to truly adopt the guidelines? And that's where we've come up with environmental assessment, various activities. but I just want you to note the most important part is the aim. What's the specific aim? What are you getting down to with the crux? And usually for a community driven, you want to make sure that it's this adoption at first. It's this overall change that is occurring first. Dr. Bazargan, do you want to add anything before we go to 2?
Yeah, I love to see that you expand our conversation, brainstorming that we had within last 2 meeting that we had with the 10 church leaders. I want them to see that, yes, we did have a brainstorming with them, but probably for 3 hours that we had a brainstorming with them, we did not talk more than maybe 10 minutes.
Mm-hmm.
We let them talk and then we learn from them. You want to elaborate on that one, Sharon?
Yeah, I can. And I think this is an important phase for every project, every community driven project that you go through. You need to have some time where you're hearing from your community partner. This is important to know that your project might change based on, just as Dr. Bazargan is highlighting, that it's important to acknowledge that they are the ones experiencing what you want to look at in the community. And because that is occurring, you need to hear from them on what they're going through and what possible, so I wouldn't even say solutions, but what methods you might try to do together to start addressing maybe some of the concerns, the challenges. Some of the things that, for example, I'll use one, is that some of the things that came out is that they really want to know more about COVID-19 vaccinations. When we wrote this grant all the way in June, vaccinations, yeah, everybody wanted one, but that wasn't at the forefront thought at that time. But now that we've gotten now 7 months later, that's on everyone's mind. What do we do when our church members are coming up to us to ask us, Pastor, should we take this vaccine? And so because of that, we have to have discussions to understand what are some of the concerns, challenges, and how can we ensure that the outcomes we're looking for, what activities do we need to change to make sure that we're not only meeting the outcomes, but we're also addressing some of the concerns that they might have. So this is why it's important. Dr. Bazargan would agree with me. It's always good to have some type of activity or some type of aim at first where you're having this bridging together with your community leaders or those advocates to ensure that when you're starting off together, not necessarily divvying up on separate paths.
I put a proposal together 25 years or something ago. Then me and Loretta went to Miss Lillian Mobley's office. And I was very, happy to see Lillian, Miss Mobley. And she looked at the proposal. I spent 6 months on that proposal all by myself. And then she looked at it. She reviewed only 2-3 pages of it, and she gave it back to me. And she said, I don't have any garbage can in this room, in this office. On your way out, there is a huge garbage can there. Put it there. As simple as this, because input of community. After I finish it, I take it to them. So it was really a piece of garbage. But I worked with Loretta Jones and a few other Aziza later, and we were able to, receive funding for the same thing. Another example is that a few years ago, I received funding from Public Housing Authority. Me and Dr. Baker and Dr. I forgot his name, Latino faculty here who left CDU a few years ago, Jose Calderon. Jose Calderon, Rick Baker, and I received funding from public housing to conduct the research in 5 public housing around us and conduct, collect the needs assessment and conduct some sort of intervention for breast cancer screening, etc. So I put together a very nice research questionnaire that Loretta helped me to make sure that this is community, culturally acceptable by the community. And then we hired the research assistant and we send it to community to collect the data. In Nicholson Garden, Dollar High, and 5 public housing in our area. And then the rate of rejections was 86% or 85%. This means that for every 10 people that we approached, we advertised everything. We did all things that you can, imagine. So for every 10 people that we approached, practically close to 9 people, they said no to us. So I didn't know what to do. So definitely the sample, data that we're collecting would not be a representative of those community because 9 out of 10, 8.5 out of 10 rejected us. So I went to Miss Mobley. I think I'm not sure whether Loretta was with me or not, and I asked her to help me. She said, I won't be able to help you. Even if I go to the community and tell them that to, answer the survey or whatever, they're not going to listen to me at this point. You got to come up with something else. I asked her, okay, I'll come back and let you know. So a few weeks later, I went back to his office and I believe Dr. Ernie Smith, Ph.D., MD, Dr. Ernie Smith, MD, was there as well. We have 2 Ernie, one is Ph.D., one.
Mohsen, sorry to interrupt, but can we give them some time to start writing their own specific aims?
I'm sorry?
Can we give the participants some time to write their own specific aims and we can go over it a little bit?
Sure. So let me finish this one in 1 minute. Anyway, so with those community individuals, we hired 10 individuals from public housing, from unemployment office. We brought them to CDU. We trained them to be research assistant for us. They went back to the community and the rate of rejection went down to 14%. Almost 8.5 individuals out of 10 individuals participated in our study. Therefore, when it comes to conducting research, developing your specific aim, hypothesis, from very beginning, you have to engage and collaborate and work with the community. Okay.
Can I add?
Sure.
I guess this is like my little tips and tricks before we get in. Can you go back to that one really quick, Dr. Bazargan, the one with the overall 3, right? I was going to add, for me personally, I love working with CDU students to train them in some type of role. That's just what I love to do. And it's to understand what is your capacity that you love to do. I like to do more training grants and then eventually or taking a training focus and using that to turn into an intervention. And that's important, but I want that intervention to impact the community. And so that's how I usually, Dr. Bazargan loves, we go in that route. And we've done it for a few grants, is how do we train? We have another one called a Tessie Cleveland clinic one. We're training the therapists at Tessie Cleveland in order to do a intervention, a mental health intervention for African-American and Latinx clients at Tessie Cleveland. So with that, we first want to make sure with our AIM 1 that what we're doing is solidifying the base. We're coming up with guidelines. We're coming up with some policy efforts. That's how we're going to implement AIM 1. With so we went over AIM 1, what that's all about. For 2, now takes where we're going to do that training. The training is where we're, oh, maybe we should have went over 1 with the activities. But if you just quickly see in 1 with the activities, we plan to do an environmental assessment. We want to do workshops. We want to engage. That's that first overall aim. That's how we usually take it, is to approach it. How are you going to solidify that plan with the community, your targeted community, and with the community leaders that you've already identified that's with you in your grant proposal? That's important. That's what Dr. Bazargan has said. Make sure that you are connected to the community, even with your grant proposal. AIM 2, because I know we're in time, we'll move back. AIM 2, training. That's where we said we want to train 30 church-based African-American young adults as health advisors. So by that, we're making sure that we're giving the outcomes. We want to train them. What's the outcomes? They're going to they're going to achieve the following, ... We're pushing that. Now you can clean that AIM to make it nicer and tighter, but with that, we're training whoever wants to be. As I said, I like training CDU students. I work here, so it's easier for me to get access to CDU students. Depending on what community you want to work with, you may, for this one, churches, we wanted to train those who are in the church. I gave the example of Tessie Cleveland. So if you're looking for that, remember I brought up sustainability. That's the important part. We want to make sure when we are finished with this study, those who are here will be able to continue on that same intervention, not needing funding or even so much oversight from those who are the leaders of it. They can continue on and the knowledge stays within the community. I don't know if I should go to AIM 3 really quick. Okay. AIM 2. So for AIM 2 with phase 1.
Yeah, well, let's try to give the students a chance to write some. We only have 12 minutes left.
Okay.
I stopped this one and we are okay. If a student would like to propose their own specific aim, then
Why don't we give a couple minutes maybe just to start writing?
Sure.
You know, do students understand the sort of the task here is, you know, from what you learned today, come up with a research idea and propose it as an aim with a hypothesis. Maybe we'll give people 5 minutes to do that, and then we can share, and Dr. Bazargan and Cobb can sort of review it.
Definitely.
we collectively could review it for you, because other the faculty and also, you know, the Dr. Friedman himself is one of the pioneer of writing grant in this institution. So if any of our students would like to write 1 or 2 specific aim, go ahead and do it. You can put it in chat or you can write it and we can give you opportunity to share it with us, that we can, you know, review it with you.
And even though, just quickly, even though we said ours is community driven, from the lectures today, you know, just hearing about it, it could be something similar to what Dr. Asari was talking about with secondary data analysis. And this relates with Dr. Shaheen and being able to come up with aims that if you are interested in doing secondary data analysis, it can follow that. So that is also another area as well.
Would it be easier for them to speak it instead of try to type it up?
Either or.
No, I think writing is good. It's good to get your thoughts in writing, I always think. And then they could share it on the chat or share the screen even and show it.
Also, if you wish to write your specific aim and later send it to us that we can review it, we will do it. But I'd love to see that someone at this point at least put one or two specific aim on chat that we can talk about it shortly, knowing that we have only a few minutes. Anyone is working on a specific aim right now? At least let us know that you're writing it. Anyone?
Don't be shy.
Yes, these aims take lots of work. Please don't be shy.
I think I have one.
Okay, beautiful. Do you want to
Alright.
share or you want to put it in the chat?
Let me
I'll read it.
hold on. Let me set this up.
Yeah.
Okay, so this is just kind of like a really rough draft. So sorry if there's like any like errors.
That's
That's the
okay.
idea.
And this is just free flow.
That's okay. Take it away.
Yeah, so pretty much I like the program that I'm in right now, or what I'm currently researching, is a lot of work on e-cigarettes, and I'm kind of doing more of the bench work associated with it, but there is an at-risk, I think, especially with the youth. And it would, and my thought would be like, oh, partner with like a neighboring high school or a high school in the area, maybe like King Drew Magnet High School, who I've had experience working with as a tutor for 9th grade students, and like train maybe like people in leadership or ASB to like maybe like 2 people per each grade, and try to encourage like, or try to like have people be leaders in terms of not, or like in preventative usage of e-cigarettes. That makes sense.
I think it makes great sense. I see it in the chat. So I see what would be the overall arching objective, which is to decrease e-cigarette use among high school students.
Right.
That's what I'm thinking. And then from there, would you be training high school leaders and ASB leadership and student council to be more so as these ambassadors, e-cigarette ambassadors?
Right.
Sorry, I shouldn't say, but to decrease their awareness. And so from there, sorry, I'm still reading. Teens are currently at risk, which can be a gateway for. Okay.
So Candace, what would be your control group?
Ooh, I'm not necessarily sure how to set up a control for this.
So if you want to test your hypothesis,
Mhm.
I think you need a control group.
Okay.
So you can randomize it to different schools.
Mhm.
You could do, 5 schools that get an intervention and 5 schools to get usual care. If you have a lot of money, you do 3 schools or something like that.
Right.
So again, this is sort of a thought in how to make specific aims quantitative, your hypothesis and specific aims quantitative, and be able to show a difference that you can then publish. I think if
Gotcha.
you just have a counselor with no control, it's not quantitative enough.
Gotcha. And we could like quantitatively measure this with like a survey at the beginning of the year versus at some point.
Yeah, right. You can look at cigarette use. I think you have to decide that. Is your endpoint cigarette use or e-cigarette use?
Right.
Maybe the e-cigarettes are going to decrease the cigarette use.
Mm-hmm.
Right. They're going to switch off of cigarettes to e-cigarettes.
Mm-hmm.
What I see here is a novel idea. The main objective here is, of course, to reduce the e-cigarette smoking. You are going to select you students as a cheerleaders, but major point here is this: what should be the curriculum that you are putting together to train those student leaders? What would be the curriculum? What are component of those curriculum? And how do you bring in the community participatory aspect of your research into developing the curriculum? What Dr. Friedman is talking about is quite important, but it comes in next step. That, you know, once you train this individual, then you compare a group of maybe a schools that have this kind of ambassador with another group of a school with no, ambassador, as Sharon named them. But for me at this point is this: what would be that curriculum? So I would say that it must be community-based participatory. You need to learn from those students. Very important. You need to learn from those students themselves that what should be the elements of your curriculum, whether it's a peer pressure, whatever it is, you got to learn from them. We have lots of theoretical frameworks that dictate to us how to deal with a student who are smoking. But if you want to truly make it effective, you have to go to those individuals and learn from them, have a several brainstorming, etc., to learn from them what should be the element, what should be your curriculum. And from my perspective, my experience, Sharon can talk about that one as well. It should be culturally sensitive. It should be multidisciplinary approach. It should be theoretically based curriculum. For example, the one that we use is called IMB model: information, motivation, skill building, and changing behavior. So how do you train? Listen to this very carefully. How do you train your student leader to do an effective job convincing their peer do not use e-cigarette? So Sharon, you want to add anything to that?
I know I see another one in the chat, but I just quickly want to add and agree with Dr. Bazargan and Dr. Friedman. I think it's a very novel idea what they said, and I agree in terms of looking explicitly or thinking about the curriculum, what important aspects. And recently I wrote a grant even with Dr. Bazargan in which we focused more on alcohol, and I wanted to train CDU students. But how I'm going to look at it in terms of a control study is looking at their number of adverse childhood experiences. And this is known as ACEs, and this is becoming an important part. And this may be easier in case you're unable to get several schools. If you're able to partner with one school, is to be able to look at what are the sorts of results coming based on the number of ACEs reported by your different ASB leaders, depending on how you'll see that intervention. I think you're building it out, and I agree with Dr. Bazargan, you'll probably have more on what are the information you want to include in the curriculum and seeing it guided. And then making sure at first it's community driven. What is it that you're learning about them? So this might take some type of qualitative part in terms of a focus group, learning what works, what type of messaging are they seeing, proceeding now to doing the curriculum. And then third will be that intervention piece. How this is now where we're going to see that behavior change. And so by seeing that behavior change, now we're going to point out where you're going to bring in that randomized control group. And that's similar to what Dr. Shaheen put with the prospective cohort study. Now I'm looking to see what are the behavioral changes. And if you're focused at one school, it may help to look at those who might have 3 or less ACEs, especially if it's a minority based school, looking at those who report 3 or less ACEs compared to those who have 4 or more. You know, you're going to find this stratifying factor on how you might randomize it, but that's my 2 cents at this point. I'm trying to make it quick.
The second hypothesis that I see associated with cannabis use, the marijuana, as you know, has been legalized in California, and that changed many things here. So we need more descriptive, explorative study to understand the impact of legalization of marijuana in California, and particularly among people with chronic, what did you say, and cannabis among Black American for chronic pain. A study that we did, Dr. Cobb, Sharon just published it. We find out that close to 9%, if to the best of my recollection, 9% of African American older adults are using cannabis. And when we ask them whether they are using it for pain or something like that, so a good number of them, I believe at least half of them, they using it for medicinal purpose, but the scenario is changing very rapidly. So this is also a very nice hypothesis, but probably I would say limit your age group. 18 to 60 is too wide, and you know, these are different group with different background, different motivation for use the cannabis. Dr. Friedman, any suggestion for that one? I guess Dr. Friedman is seeing patient. Okay.
I'm here.
Yeah.
So again, I think is the control group is important. Are you doing groups?
Sorry, Dr. Freeman, go ahead. Sorry, my apologies. Go ahead.
Groups, or is it a comparison study?
Yes, I'm hoping to do a comparison. I'm only going to have 30 people because it's a very small pilot. And so, you know, I don't want to use the word underpowered, but it's just not that many participants. So I thought if I were to have like heavy, moderate, and non-cannabis users, then that would only get me 10, 10, 10. And that wouldn't really get me, you know, a lot to be able to really compare. So I was just thinking about just doing, again, like people who are heavy cannabis users. So I'm gauging that by like at least 3 times a week, and moderate. So once 5 times a month.
Why don't you do non-users?
I thought about doing non-users and users. I thought about that as well. Yeah, so that I guess that could be another option, just to do 15 and 15. You're thinking?
Yeah, I think that's. You'll get more, you know, all your users. You could do all of them, and then you could do some kind of covariant analysis to see whether heavy users have more of a effect than the light users.
I was
Okay.
gonna add, probably because it might be intense, because the sample is smaller, is possibly adding a qualitative component just in case. You know, I always
Oh yes, that's
say,
aim one. That's aim one.
okay, great.
I didn't put that here. This is aim two. I was trying to
Okay,
get quantitative piece. That's aim one.
Okay, perfect. I was gonna say that just in case, you know, because that's sometimes your saving grace when the sample size is small. So yes, perfect.
Yeah, and also, do you remember this morning, Dr. Martin Lee talked about matching, stuff like that? So if you are selecting 3 groups, one heavy, one light, and one medium range of marijuana use, so you need to, since your sample is quite small, maybe you need to do some sort of matching. For example, level of pain maybe should be the same among all of them when it comes to gender and age. It's difficult with matching because you have to look around and find, similar individuals with similar demographic characteristics for each group. Otherwise, it would be very difficult to document the differences between these groups. Magda is very good.
How are you? Can I say something? This is Magda. How are you doing?
Yeah, sure. That's why I invited you to say that. Go ahead.
Oh, thank you. Because usually when we do case control study, because of the selection bias probability, we do matching so we can avoid some of those selection bias of the population. But it doesn't sound to me that she is going to do a case control or even a cohort. It could be like a cross-sectional.
Mm-hmm.
So cross-sectional, you need to estimate the sample size, and we have like the software available. We can help with that. And you can collect the data and analyze it, but you have to estimate what's the minimum sample size that you need to achieve the response to your research question.
Thank you, Dr.
Yeah, so I think, Delara, you should be in touch with Magda, and she can help you with the sample size issues and the design issues.
Okay, I'll reach out. Thank you.
We
Thank
will
you.
be very happy to help you, my dear. So
Okay.
you can just send me an email and I will be happy to schedule a meeting with you and discuss. Thank you.
Sounds good. Thank you so much.
And also, you just selected one characteristic, and that is impulsive inhibition, right? I would say that go beyond that and maybe you select some other characteristic that maybe if one is not associated with what you want to find, so maybe the other one helps, just since you're doing it, expand it to a couple more personality and characteristic. Sharon?
Can I just add quickly, just to know, it's more about the population, the sample. Maybe, for instance, it's going back to Dr. Bazargan's point, I would highly encourage you to limit what age group you focus on, whether it's middle age, adult, because 18 to 60 is such a large group. And then cannabis, cannabis is becoming such a big area. And one of the things that's really, if you're going to focus on chronic pain, is to know if it's medicinal or recreational. I think in knowing what types of cannabis you buy, because we know that it's having effect, especially if you're looking at executive function with impulse. I think that's important to know what type of cannabis that person may be using, just so it can it can add more rigor in terms of the study to be clear, to have more clarity about that. So that would be my take in addition with everybody else.
Thank you, Karen. And also I emphasize again that the issue of the pain, chronic pain, has a wide range. You can talk about palliative care all the way down to back pain. So you have to be very careful that what kind of pain you're talking about. Are you talking about terminal illnesses? Are you talking about only pain that you have more, kind of sample that people who are reading your report, they don't question you about, different type of pain, different chronic condition, different level of life. So limit yourself to very specific group with a specific pain, maybe back pain, and not individual with, life-threatening or cancer or something like that. Just, this kind of stuff. Am I making sense, Dr. Friedman?
Yes, you- Yeah.
Severity of pain is very important factor that you have to take it into consideration. Thank you.
I'm going to log off, but if people want to stay to discuss with Dr. Bazargan and Dr. Cobb, please go ahead. I think we're going to have another session in the spring on sort of grant, maybe a whole series on grant writing. So this is a little teaser, but think about projects. And I thank everybody. You guys can go on.
If you wish to write your hypothesis, shoot it to Dr. Shaheen, me, Cobb, and everybody else, or send it to Christina, and she can distribute it among us. One thing that I want you to do, write your general goal, write your specific aim, write your inclusion and exclusion criteria. That's it. When we said general goal, why you are doing that, and then a specific aim, you said, this is my specific aim and this is my hypothesis, and then be very specific about exclusion and inclusion criteria. Remember that no one expects you to do a perfect job. The objective of this training and workshop is to help you to step up and learn. So don't worry that Magda, Mohsen, or Sharon is not going to like this hypothesis. That's not the way it works. Remember, there is no stupid question. There are always a stupid answer, but there is no stupid question. So ask your question, write your specific aim, your hypothesis, general goal, inclusion and exclusion criteria. We will try to shape it for you, and with help of Magda and Dr. Friedman, etc., we come up with some, some reasonable proposal for you. Well, it is Friday afternoon, 4:30. You all have a wonderful weekend. I hope you enjoy it. Dr. Booker, Leo.
Have a wonderful weekend.
Thank you. We have to go. Thank you.
So I put a link to an evaluation on the Institute in the chat, but I'll also send it out via email since most people are gone. But thank you all for hanging in there.
Wait,
Thank you.
wait a minute. I want all of you put your hand together for Christina. She works very hard.
Thank you, Dr. Bazargan. Thank you. I'm taking a bow. Thank you. That's very kind of you. Thank you so much. Thank you, everyone. And then our next Institute will be February 19th. So in a couple months, we'll have the next one. So thank you so much.
Thank you.
Thank you.
You guys.
Thank you.
Bye.
Bye. Good night.
Bye.